Last topic that we're gonna do is transcranial Doppler. So these are kind of interesting if you ever get an opportunity to observe transcranial Doppler exam. There's a couple different methods. There's the traditional transcranial Doppler where you're just using a Doppler probe. So basically what we utilize for the PVR SLP, just a Doppler signal, where you're just getting the waveforms. Or you can actually utilize an ultrasound machine to get color images. So you actually visualize the vessels. So again, depends where you are, what type of machine that they use, and the method that they use to assess the cerebral vasculature. So this is primarily looking at the circle of Willis now and the vessels of the circle of Willis. So this is just some background information about transcranial Doppler when it was first utilized. So it goes all the way back, to 1982. So transcranial ultrasound offers multimodal, high-resolution, real-time imaging of the brain's structure and vasculature. So it's an important non-invasive way to assess the cerebral vascular hemodynamics, the function of the central nervous system, and evaluating for intracranial cerebrovascular disease. So when we get further into the lecture, we'll see that, we can use our Doppler waveforms to determine brain death, in patients, who might have had some sort of traumatic brain injury. Because we could see changes in those Doppler waveforms as the brain starts to deteriorate and eventually that patient goes into, brain death. We can use it for assessing. One of the primary uses we're going to see is for monitoring for potential vasospasm. So patients who have any sort of traumatic brain injury or brain bleed, particularly subarachnoid hemorrhage, they're prone or susceptible to developing vasospasms. So the actual arteries of the circle of Willis will spasm up and the walls will become thickened, and then the vessel becomes very, very narrow and creates a stenotic lesion. And that could cause further brain damage if, again, the territories aren't receiving adequate blood supply. So we're going to measure blood flow velocities in those basal arteries and the circle of Willis. So the branches of the circle of Willis, the communicating vessels as well. So we'll assess blood velocities as well as the flow direction. So direction we're going to learn is very important in determining, the presence or absence of disease. So for transcranial Doppler, when we just use that little pencil probe, it's a 2 megahertz pulsed gated sample device or Doppler device with good directional resolution. So it has to be a very low frequency to penetrate through the bones of the skull. So we need, around 2 megahertz. If we're doing with the actual ultrasound machine, it's going to be about 1.8 to 3.6. So again, a low megahertz transducer. So in vascular, we're usually using 5 to 7, to get nice resolution. The abdominal probes, what are they? They're like 2 to 5, right? I think for the curve probe. So with this, we're on the low end of the scale. So typically around a 2 megahertz transducer, is what you're going to be using. The other important part of that is that it's pulsed wave and not continuous wave. So with that we used back there, that was a continuous wave Doppler. So it had 2 crystals in it, one continuously transmitting, the other listening for that echo signal back. With transcranial Doppler, we need a pulsed wave Doppler. So when we get into physics, you're going to learn all about the difference between pulsed wave and continuous wave. But the reason we need pulse wave is because we need to be able to place that little sample gate. So, when we have our Doppler signal or caliper, it's those 2 little parallel lines that refers to our sample gate. With white chalk. We had that, that Doppler line. We had our sample gate. And then we had, the Doppler angle that kind of went through it like that. That sample gate, we need to be able to position it at a specific depth when we're imaging the different vessels of the circle of Willis, because each vessel lies at a kind of a general depth. It's different, obviously, for every patient. Some people have big heads, some people have small heads, fat heads. No, it all depends on the patient. We need the ability to place that sample gate at a specific depth, and that capability only comes from pulse wave Doppler. So sending out ultrasound pulses. With the ankle, with transcranial Doppler, the angle is always gonna be 0 degrees. So I had told you guys, with the crowd Doppler, should keep it at 60 degrees or just always keep it below 60. With transcranial Doppler, the angle is always gonna be assumed to be 0 degrees. It's always gonna be a 0 degree angle. So that's kind of one of the differences when we're talking about vasculature. So it's a pulse rate Doppler, low frequency, so around 2 megahertz, and the angle, the Doppler angle is always going to be 0. So that's your traditional transcranial Doppler. We also have TCCS. This is transcranial color-coded duplex sonography. So this one utilizes the ultrasound machine now, where we get that grayscale image with the color Doppler, and then we can actually get visualization of the vessels on our ultrasound machine. So with that, since we can actually see the vessels, we can do slight angle adjustments to get more accurate velocity measurements. This is actually the cardiac probe basically that we use. So if you guys ever want to play around with it, we can do that one day, maybe next year, try and see who's got good windows, transtemporal. You can actually see pictures of the circle of Willis. We can get Doppler images and visualize everyone's circle of Willis and just using the echo probe. Now with the advent of 3D ultrasound, we can utilize our ultrasound machines and actually get 3D renderings of the circle of Willis and the cerebral vasculature. And then now with the advent of contrast agents as well. So our ultrasound contrast agents allow for better visualization of these vessels. Because again, it is kind of hard, it's limited. Not everyone's got the best windows. The vessels could be a little bit deeper. It's hard to, again, penetrate through the patient's skull to be able to visualize the vessels. So with the use of our ultrasound contrast agents, which are essentially just small micro bubbles that act as very strong reflectors, it helps us to really illuminate those vessels and allow us to visualize a lot clearer the circle of Willis and that intracranial blood flow. So additional ultrasound instrument requirements, we need a very large signal to noise ratio. And we want a very narrow bandwidth. Transmitting power ranges, so don't worry about transmitting power ranges, but really the most important thing is having an adjustable Doppler gate. So again, we want to be able to adjust the depth of our Doppler sample gate. Pulse repetition frequencies are going to be less than 20,000 hertz. And focusing the ultrasound beam at a distance, between 40 millimeters and 60 millimeters from the probe. On that Doppler display, you're going to see a couple displays for velocities. There's going to be a time average velocity as well as the peak systolic velocities on there. They've developed specialized equipment. It's almost like a helmet, or it is a helmet that has multiple Doppler probes attached to it to monitor through various windows simultaneously, so they can assess all multiple vessels at a single time for patients who are in the ICU, the intensive care unit, and are necessary for continuous monitoring of transcranial Doppler vessels. Well, are you okay? I'm just in class. All right. I'll talk to you later. Bye. So capabilities for our transcranial Doppler or our TCCS. We can assess for stenosis, narrowing of the vessels, occlusion of these vessels. It's utilized often in screening of patients with sickle cell anemia. So those of you in the DMS who rotate through Nemours, when you have your sickle cell patients, they often order transcranial Dopplers for these children who have a sickle cell emergency or sickle cell crisis, and they're worried about and they're exhibiting some sort of stroke symptom. We can detect arterial venous malformation, so fistulas between the arterial and venous system that are congenital, patients are born with. Again, it allows for monitoring of these intracranial vessels and evaluating for vasospasm. For patients that are status post subarachnoid hemorrhage for brain bleed, we can use it to detect emboli circulating through our cerebrovascular system. So again, with stroke patients that maybe have little pieces of atherosclerotic plaque that are circulating through their system, we can pick that up. Patients who may have had a DVT or a blood clot in the legs, we'll see there's a certain condition where they have what's called a patent foramen ovale, so basically a hole between the right atrium and the left atrium that would allow blood clots to go from the venous system, cross over the heart right into the arterial system on the left side, and then potentially embolize and cause a stroke. Again, we can use it for detection of impending brain death or brain death. And we evaluate the hemodynamic effects of extracranial occlusive disease. So we could tell if patient, like we said, the most likely location for carotid artery disease is the carotid bulbs and bifurcation. So if a patient has extracranial disease, we can see the hemodynamic effects within the circle of Willis and how significant that hemodynamic lesion is and how much of an effect it has on our cerebral flow. So it's considered a functional test. Again, it's also if we have, particularly if we have that color coded sonography, it's considered brain perfusion imaging. We can also potentially use it for, we're going to get later in the lecture, potentially use it for newer, newer uses is utilizing this transcranial Doppler for thrombolysis, where we actually break up clots within, the cerebral vasculature, utilizing either ultrasound machine or that transcranial Doppler to actually rupture those contrast agents that we administer. Because we can actually put thrombolytic medication within the contrast agent bubbles. And then when the ultrasound beam hits those bubbles, they rupture and burst and releasing their thrombolytic medications in a specific targeted area. So these are just some main indications now for transcranial Doppler in our TCCS. In terms of patient preparation, main thing is you want the patient lying still and comfortable. So supine, you have the head slightly elevated, they're more comfortable sitting, as long as they can maintain, that position without moving. Sitting, again, they want to avoid speaking, and scanning to avoid any movement artifact or fluctuations in blood CO2 levels. Also important for you is to know the status of their extracranial vessels. So we want to know, do they have any cerebral vascular disease in the carotid arteries before we do this transcranial Doppler. So there's some specific windows that we need to learn in order to be able to perform a TCD exam. So it usually starts with our transtemporal window. From that transtemporal window, we can see the majority of the vessels of the circle of Willis. And we want to note any changes in velocity, the flow direction, and the traceability. So there's our circle of Willis now. So you kind of have to, again, visualize yourself looking down on the circle of Willis from that bird's eye view to kind of get your orientation. So anterior, posterior. So front of the head, eyes, front of the face, back of your head, and then your two sides. So coming from your temporals would be, your right and left sides coming lateral. So from that transtemporal window where we come from the side and image that circle of Willis, depending on how we angle our transducer or our probe, we can angle it more anterior to get, the structures, middle cerebral, anterior cerebral, ICA, or we can angle it posterior from that same window to get, our posterior cerebral, posterior communicating, basilar artery. So again, depending on which way your angle and tip your transducer, you can essentially see pretty much all the structures within that circle of Willis coming from that transtemporal window. There are some of the windows now. So transtemporal is where we start our examination. If we angle anterior to your middle cerebral artery, the carotid siphon, anterior cerebral artery, anterior communicating artery. If we angle more posterior now towards the back of the head, you can see posterior cerebral artery, basilar artery, posterior communicating artery. The second window is a transorbital window, so right through the patient's eyeball. With that one, we get good images of the ophthalmic artery as well as the carotid siphon. So we use that to really assess some of the anterior cerebral circulation. We have a suboccipital window. So suboccipital is kind of right in the middle of the back of the head, through the foramen magnum. So that's where the spinal cord enters into the skull. From there, we can see good pictures for our vertebral and basilar arteries. So we can see both vertebral arteries entering into the skull, coming together and forming that basilar artery. And then the fourth window is a submandibular window. So just under the jaw, under the mandible, you can kind of really angle superior and get that distal portion of the ICA. So kind of going where, ultrasound can't go. So when we're imaging the carotids, we come up to that jaw, we can then kind of dip under it with this probe and try and angle up and see if we could see the distal ICA, intracranial. Yeah. 4 windows, transtemporal, transorbital, suboccipital, and then submandibular. But transtemporal window, windows are a little bit different, for each person. You kind of have to navigate and search around for where that patient's clearest window is. It's, going to be in front of the patient's ear, sometimes a little bit above the ear. So you have to kind of play around and see where their window exactly is. Kind of similar to echo when you're looking for your windows. So you're kind of just navigating, searching around. So with this, view, the reason we use that phased array is because it begins at a nice point and then fans out. So as it fans out, it allows you to visualize again the structure of those circle bursts, which are lined and green. So again, if you're just kind of orienting, you listen to anterior now, posterior, so the back of the head, front of the head. Again, if you angle anterior, you can see anterior cerebral artery. Fan more posterior, you can see the posterior cerebral artery, potentially the basilar artery coming in. So with the probe positions, you also have to start becoming comfortable with understanding the flow directions and how the blood flow would be coming either towards you or away from you. So recognizing normal and understanding normal will help you to better assess and understand abnormal. So again, just kind of visualize, the probe sitting there and the flow direction of the vessels, what they would normally be. So again, if my probe is, sitting in this transtemporal window, the middle cerebral artery on this side, blood flow should be coming towards my transducer. So then if I don't have a color image and it's just a transcranial Doppler, the waveform would be above the baseline because it would be a positive Doppler shift towards you. That same window, and I'm angling now towards the anterior cerebral artery a little bit. So I angle a little more anterior, trying to get the anterior cerebral artery. In that case, normal flow would be away from my transducer. So it'd be a negative Doppler shift away from my transducer ultrasound beam. That Doppler waveform is going to be below the baseline now. So that's how you kind of figure out, without a picture, which vessel you're really looking at. That's why knowing whether or not they have disease before you go in, it really helps. So if they haven't included ICA on this side, that there's no blood flow getting up that way, then you can assume, things might be going on where we might be getting blood supplying from the other side, coming up that ACA across the communicating and then back down the anterior cerebral to kind of fill, that portion or that segments of the brain. So if you know what's going on before you get into that exam, so when you're angling, you know that, and you see what you think should be, the direction and depth of the anterior cerebral artery. If it's retrograde flow or, blood flow coming towards you, it makes sense based off, what their cerebral vascular, their carotid duplex is telling you. So other vessels, so normal flow direction and posterior communicating should be from the ICA down into the posterior cerebral arteries. So normal flow direction flows from anterior to posterior within those vessels. Again, if we know the status of their carotid duplex, we can recognize, what we can potentially see with abnormal flow direction. If we angle posterior from that window, posterior cerebral artery should be coming towards you in that P1 segment. And then some patients, as it dips down, it starts going away from your transducer again, or your ultrasound beam in that P2 segment. So it's kind of towards and then away. Basal artery, if you really angle posterior, should be coming towards you. So it's a positive Doppler shift above the baseline. Chart that shows kind of the distances. This is showing, what your typical screens would look like when you're doing these transcranial Dopplers. Under, the velocity measurements, there's going to be a peak velocity, there's going to be a mean velocity. There's going to be a pulsatility index. So with this, we want to look primarily at the mean velocities. That's really what we use to calculate when we're looking at stenosis and potential vasospasm is those mean velocities. So we look at the average velocities for these vessels. On here, you'll also see depth. So you know how deep, your sample gate is. Then this is with the color-coded sonography. Here we can actually see, the circle of Willis. We're coming from a transtemporal window, that middle cerebral artery coming right at you. So in terms of our waveforms, they should look like our ICA waveforms. They should be nice, low resistant waveforms, lots of diastolic flow, because these are cerebral vessels feeding the brain. Most transcranial Doppler exams, most techs will start at the bifurcation between the MCA and the ACA. So this is kind of your landmark where you can kind of figure out, kind of get your bearings, get your orientation down. It's going to be a waveform that almost looks like a mirror image of each other, but it actually is two distinct vessels. So in this case, we said that middle cerebral artery blood flow is towards the transducer, so it'd be above that baseline. So this represents your middle cerebral artery Doppler waveform. And then anterior cerebral artery is away from the transducer, so that's represented by a Doppler waveform below the baseline. So if you can kind of use this as your landmark, you can begin your Doppler exam. So basically what they're trying to get for is this area right here, where you're coming in, you're instigating this kind of spot right here, and you know the general depth of this, or you have your depth setting, you know how deep you are. You're trying to image and angle and manipulate to get the middle cerebral artery coming towards you, as well as the anterior cerebral artery going away from you. So you're kind of trying to target that spot right there. And then from there, you can kind of figure out, all right, I have to angle a little more anterior, increase my depth a little bit, try and image the anterior cerebral artery by itself. Decrease your sample depth a little bit, maybe you have to angle a little slightly posterior. So it's a real finesse exam. This takes a lot of, experience to be really able to master, particularly when you're just doing the Doppler without the actual image itself. This is that MCA ACA bifurcation. So again, if you're on any sort of board exam and you see a transcranial Doppler waveform that looks like this, where you see above and below the baseline. Another way I can also kind of tell I'm in this area too is the one on top should be higher velocity. The middle cerebral artery, one coming towards you, out of all the transcranial vessels, will have the highest velocity. Next highest is going to be your anterior cerebral. So this one should be a larger waveform. You should have a higher mean velocity compared to the ACA. You can angle a little more inferior and get that distal ICA. So from that same transtemporal window. And then if you angle a little more anterior and superior, increase your depth now, your sample depth, you can get just the ACA. But here you see just the ACA by itself. So again, this is away from the transducer. The flow direction and the Doppler waveform should be below the baseline. With a posterior orientation now, we can Doppler the posterior cerebral arteries from that same transtemporal window. So we angle posterior and inferior. Just increase our sample depth. And in this case, that P1 segment, that first segment of posterior cerebral artery should be towards the baseline or towards the transducer, so above the baseline. And then that P2 segment kind of dips down. So depending how far out you are in that P2 segment. So P1 is towards you. So if I get transtemporal, ultrasound beam is directed, they're converging, coming together. So we should have a positive Doppler shift above the baseline. Then as it goes around that turn and away from the transducer, you get a Doppler signal below the baseline. So for transcranial Doppler, through that temporal window, we need to, be kind of familiar with our instination depths. I'll be perfectly honest, boards doesn't really ask about all these instination depths. They want to know primarily flow direction, understanding, which way you're angled to get these vessels and the flow direction, and then general velocities. So I have a nice little chart kind of a little bit later that kind of breaks down the velocities. So the transorbital approach. So this is actually through the patient's orbit, through their eye. So transducer is placed on a closed eyelid. So they close their eyelids. I tried doing this on myself and like with one eye open, and this one tries to blink with the other one open. It's not good, and then you start getting gel in there and going on. Fast ticket to pink eye, I guess. Right? So transorbital approach. So from here we can get good images for the ophthalmic artery as well as this carotid siphon. So where the ICA does this kind of like S loop. So this is referred to as the carotid siphon. We can also see anterior cerebral artery as well. So in this case, so here's our carotid siphon where it does that little loop. First branch of the ICA. So this is the segment of the internal carotid artery. That ophthalmic artery. So we can see the ophthalmic artery going way out to the eye. So in terms of flow direction, normal flow direction should be towards that ultrasound transducer. So we should have a Doppler shift that's above the baseline for our ophthalmic artery. Depending on the segment of that carotid siphon that we're imaging, it could be towards and then away from the transducer. So for instination of carotid siphon and ophthalmic artery, we like to utilize that transorbital approach. transorbital approach. You can see some slight differences in the waveform with the ophthalmic versus the carotid siphon. So again, ophthalmic artery is going to be much higher resistant. Think of the eye kind of as a muscle. You know, it's going to be higher resistant, much higher resistant compared to the actual ICA itself. Then with our color-coded sonography, so you can actually see, so that black anechoic area is the actual eyeball orbit. You can potentially see the optic nerve appears more hypoechoic. You really don't see, you know, the walls of the vessel or anything like that. You have to put your color Doppler on to actually really visualize the vessel. Right here, now you can see the ophthalmic artery red, so that indicates towards the transducer. And then we could try and Doppler and get Doppler tracings, you know, for our vessels. So this was showing ophthalmic artery, segment of that carotid siphon much deeper.
So it's low resistant, right?
The ICA is low resistant, the ophthalmic artery is gonna be higher resistant. It's gonna look kind of like an ECA. So suboccipital window now. Also called the transforaminal approach. Is utilized to visualize our vertebral arteries, our basilar artery, and potentially the posterior cerebral arteries. But really primarily vertebral basilar. So with the suboccipital approach, you have the patient sitting with the head forward and flexed, supine. They're lying supine, you can have them turn their head with the weight from you to one side. You can potentially decube them if you wanted to, if that's more comfortable for the patient, turn them on their side to cube them. So from that suboccipital window, we're gonna angle slightly to the left or slightly to the right. Try and get a good window, try and visualize both of the vertebral arteries coming in. So in terms of flow direction now, blood flow's coming up the neck, vertebral arteries coming in and it's gonna be away from that transducer. So we should have a negative Doppler shift and a Doppler waveform below the baseline now. So normal flow direction for vertebral arteries, as well as the basilar artery, is going to be away from the transducer. So a negative Doppler shift. Just now showing basilar artery after they come together. So we increase again our sample depth. We're just doing with the TCD. The negative Doppler shift below the baseline, away from the transducer. Then with color-coded sonography, it's gonna look like a Y. So it's the two vertebral arteries, you know, coming together, forming that basilar artery. So blood flow, normal flow direction should be blue. If blue represents away from the transducer. So again, just be careful of what your color map is set up to, because this could be inverted or flipped. Just know that normal flow direction is going to be negative Doppler shift away from that transducer. Submandibular window is what we would utilize to visualize the distal ICA. We come below the patient's mandible, angle superior, try and Doppler segments of that distal ICA intracranial. So with this, flow direction should be away from the transducer, negative Doppler shift. Should we have a waveform below the baseline? So this was that helmet or head apparatus that they can utilize to perform transcranial Doppler, multiple, windows at the same time simultaneously, continuously running. So again, this could be done patients that are intraoperative or in the ICU. So these are, again, our transcranial Doppler reference points. So again, you're gonna be looking for your MCA, ACA bifurcation. You're gonna have to Doppler middle cerebral artery, anterior cerebral artery, anterior communicating, posterior cerebral, posterior communicating, vertebral and basilar. So the basic exam is primary diagnostic measurements for identifying the cerebral arteries. So we want to know our instination depths, the direction of the blood flow at that depth, the flow velocity, so mean velocity, systolic and diastolic. The site, so which window are we coming from? Direction of the ultrasound beam, so are we angled anterior, or are we angled posterior? We're gonna try and reproduce these vessels to make sure that we have good traceability, that we can measure accurately, properly. So we want to have a nice, clear spectral Doppler tracing. After completion of the examination from both temporal windows, additional information may be obtained through the orbital, suboccipital, and submandibular pathways. So this was just kind of showing some reference depth. So this is kind of the general rule of thumb in terms of depth. Your mean flow velocities in the different vessels. Your general flow directions. Flow direction. Next one. Really very normal flow directions and velocities. So a good rule of thumb, just kind of use 100 as your baseline when we're talking about adults in terms of velocities. So anything over 100 would technically be considered stenotic. Different facilities and different labs have different charts and values that they utilize. So Christiana has like an 80 to 100 is being like kind of mildly stenotic. I think they have 100 to 120 moderate. Is their chart? I have Christiana's chart here. We'll get to it. I like to say middle cerebral arteries generally towards. I know some textbooks would say bidirectional for that M2 segment, but middle cerebral arteries generally towards. Anterior cerebral artery is going to be away from the transducer. That carotid siphon, depending on how the loop is, could be bidirectional, so it could be either above or below the baseline, depending on what segment you're in. Ophthalmic artery is always going to be towards. Posterior cerebral artery, again, depends if you're on that first segment, the P1 versus the P2. So P1 would be towards your transducer, P2 would be away. Vertebral and basal artery are always going to be away from the transducer, come from that suboccipital window. Some of the things that can affect blood flow velocities, age. So as you age, velocities go down. So that's why we have different criteria measurements for children versus adults. So again, if we're doing this on a child, Nemours, so sickle cell patient, their normal range is much higher than compared to an elderly adult. So velocities decrease with age. Gender also has a role in it too. So velocities are 3 to 5% higher in females than they are in males. They are the smarter species. Vessel diameter. So as the diameter decreases, think of stenosis, we get more narrow diameter, velocities will increase with stenosis. That plays a part of it. hematocrit, so if the blood is very thick versus very thin. So patients who have very thick blood will have lower velocities. If they have a very low hematocrit, blood's able to flow more freely, lead to higher velocities. Blood pressure has a role as well. So if you're very hypertensive, you have elevated pressures, you're going to have elevated systolic velocities. O2 concentration, so the amount of carbon dioxide in your blood. So CO2 acts as a vasodilator. So when vessels dilate now, that allows for increased blood flow. So we'll see increased flow and velocities within those vessels with increasing CO2 levels. Cardiac output, so if a patient has a weak heart, they're going to have slower velocities. If they have a stronger heart, they're young or athletic, they'll have higher velocities. Medications, metabolic factors also play into that. So again, the highest velocities are almost always found in the middle cerebral or the anterior cerebral artery. Lower velocities are seen in the posterior cerebral, basilar artery, vertebral arteries. So just think about it, just logically, we know that the ICA has higher velocities than the vertebral artery. So consequently, the cerebral vessels within the circularis are going to have slower velocities, the ones that are fed by the vertebral arteries compared to the vessels that are fed by the ICAs. So this was just showing how the average mean velocities, decrease with their age. So younger patients, 10 to 29, got much higher normal cerebrovascular velocities compared to someone who's older. So this is kind of the general rule of thumb. So middle cerebral, typically the fastest, 60 centimeters per second. ACA is about around 50 centimeters per second. Posterior cerebral and basilar are going to be slower compared to the anterior circulatory pathways. So posterior circulatory pathways, slower velocities than the anterior circulatory pathways. So MCA, ACA are going to be higher than the PCA and basilar. So we need to figure out, if there's stenosis. That's the main thing that we're looking for. Is there blockage? Is there stenosis? Is there occlusion? So in addition to looking at the actual velocities, the speed of the blood flow, we could also utilize a velocity ratio, or in this case, we call it a hemispheric index. So this is kind of similar to that distal ICA to distal CCA. In this case, we're comparing the middle cerebral velocities to our ICA velocities. So we want to figure out for, in this case, whether or not the patient has a true vasospasm. So we said the most common vessel to vasospasm is going to be your middle cerebral artery. So that's the primary vessel we look at for detecting vasospasm. So we want to see if this patient is having vasospasm within their brain, and now those velocities are elevated. We're going to compare it to our ICA velocities to see if both of them are elevated, or is the patient just having vasospasm and this velocity is elevated. So we get this ratio, this index. So if a patient has a true vasospasm and this velocity goes up, this is going to create a much higher ratio because this one's not going to be affected. So if I kind of just put numbers in there, so normally, maybe we get 200 middle cerebral, well, that's elevated. So we'll say 50 and 100. So that's, I'm sorry. Yes. So we'll say 100, I want to use that, 50 and 25. Because the velocity, the ratio has to be over 3. If we get increased velocities with that vasospasm, this number is going to go up significantly and increase our ratio. So that's one of the markers that we can use to determine vasospasm. When we get an index that's greater than 3, that indicates pathology. So basically 3 times, the velocity. Just things have to use such small numbers. So again, this will indicate patients that are either in a hyperdynamic state versus having true vasospasm. So hyperdynamic means they have increased blood flow. Hyperemia is another term that you can utilize and just means systemic hyperemia. There's increased overall global blood flow, so increased flow in both sides. So if it's just hyperemia and there's just increased flow, both of these numbers will increase equally and not affect that ratio. So a protocol like Christiana, through that transtemporal window, they image middle cerebral artery, that bifurcation, the MCA ACA bifurcation. So again, most texts will flip flop that. They'll try and find that bifurcation first, as their kind of their landmark or their home, and then go from middle cerebral and anterior cerebral image posterior cerebral artery, and then the posterior try and image the terminal ICA, the angle a little inferior to get that, and then try and get your communicating arteries, your anterior and posterior communicating arteries. Through that transorbital window, they'll Doppler the ophthalmic artery, take a look at the flow within the carotid siphon, and then they'll move to a suboccipital window to image the vertebral and basilar arteries. And then they'll end the exam coming submandibular to image the distal ICA. The intracranial stenosis and occlusion. So with stenosis, any stenosis, we look for increased flow velocities, disturbed flow, spectral broadening. So it might be co-vibrational phenomenon. So if there's, high velocities, turbulent flow, the vessels might vibrate, creating that spectral broadening. Some conditions are hard to distinguish from stenosis. So we might have intracranial arteries providing collateral flow. So meaning one side is disease, the other side is acting as collateral pathway when we have disease on one side. So that might have falsely elevated velocities because it's acting as that collateral. When there's arteriovenous malformation or fistulas that are, congenital malformations, these AVMs, the feeding arteries will have elevated flow. Those are very hard to localize. And then vasospasm. So instead of having a true blockage or narrowing, maybe some sort of atherosclerotic plaque that's developed and is creating narrowing, the patient might be experiencing vasospasm. So this is more generalized, and the changes are progressive over time. Thus, with vasospasm, we see a gradual increase in those velocities as the spasm progresses and develops. You can also potentially see occlusion of vessels. So if the vessel is completely occluded and there's no blood flow, there'd be absence of any arterial signals at an expected depth range. So you can imagine it's kind of hard, to really ultimately rule out occlusion when you're doing a transcranial Doppler and you don't have that picture there to actually visualize the vessels. You're just kind of assuming, you're putting in your best effort. You're trying to find, either anterior cerebral or middle cerebral artery where you expect it to be, and you can't detect anything. If you can't pick it up, you have to go under the assumption that it's possibly occluded if you're not able to obtain any Doppler signals. With occlusions, there's going to be potentially alterations in flow directions in some other vessels that you can utilize to make that diagnosis of occlusion on one side or the other. So presence of signals in vessels that communicate with that occluded artery we're going to look for. Again, typically I like to use 100 for, that mean velocity indicating stenosis for our anterior cerebral vessels, posterior cerebral vessels, the baseline vertebral over 80. So this was showing MCA stenosis, and they Dopplered at different levels within that stenosis. So they got the normal velocity within proximal to that stenosis. They started sampling or moving their sample gate further a little more shallow, so they decrease the depth, kind of moving along the middle cerebral artery, trying to find maximum flow velocities. So when they got into the area of the actual stenosis, they were able to demonstrate markedly elevated velocities. You got turbulent flow filling in of that spectral window. They moved a little bit further, and they actually got into the actual stenosis itself now, with some post-stenotic turbulence now. The peak velocity is 206, the mean velocity is 106. They're showing now left MCA stenosis. Mean velocity is really what we're looking for. So those mean velocities are 171, so that's over that 100, threshold. This is just showing Dopplers in the M1 and M2 segments in that middle cerebral artery. So it went from 66 up to 182. This a doubling of velocity indicates greater than 50% stenosis. And that also, again, falls under that stenotic range over that mean velocity of 100. So this was just showing some digital subtraction angiography. So they actually did an angiogram to visualize the vessels intracranially, to kind of correlate with what they were getting with the transcranial Doppler. So we could see some flow. So on the side, pre-stenosis and then stenosis. So it looks like you can also look at the resistive index, or the resistance of that vessel. So if we're doing a transcranial Doppler and we're imaging middle cerebral artery or anterior cerebral artery, we know right away this is not normal for in the brain. So this looks like an ECA, or it's a very high resistant waveform. So we shouldn't expect to see this within the brain. So this would be, again, an example of a pre-stenotic Doppler waveform coming from a pre-stenotic zone. So this would typically indicate to someone that there's an occlusion or stenosis further downstream within that vessel. So instead of resistive index, they use pulsatility index with transcranial Doppler. So it's similar to resistive index, but instead of dividing by the peak systolic velocity, we're dividing by the mean velocities. So again, transcranial Doppler, we're focused more on the mean velocities. So that's why they utilize pulsatility index versus resistive index. So with pulsatility index, we can have values that are obviously over 1 now, since we're dividing by a mean. But it's similar. The higher the pulsatility index, the higher the resistance. Just kind of equate those two to being kind of one and the same. Pitfalls patients might have poor acoustic windows, lack of signal strength. We might misrepresent a patient who is hyperdynamic or hyperemic and have that collateral flow compensating and overestimate our values. Displacement of arteries because of space occupying lesion. So if a patient has a large brain bleed that's kind of displacing everything, or if they have a brain mass or tumor, God forbid, things might be shifted. There might be physiologic, variations within that circle of Willis. So patients might have anatomical variants within the circle of Willis that we're not able to see because we don't have actual images of the vessel. We might misdiagnose vasospasm as an actual stenosis or blockage. And then Other pitfalls, difficulty visualizing the vertebral and basilar or making those diagnoses. So normal flow and the size of the vessels are highly variable, particularly with the vertebral arteries. Location and course of the arteries are also unpredictable. Often the junction of the vertebral arteries cannot be readily identified. So a lot of patients, you might just see the two vertebral arteries kind of coming in, but you don't actually see where they join together to form the basilar. Absence of vertebral flow signals on one side may not represent the disease, so we may not see again both vertebral arteries depending on the patient's imaging characteristics. Occlusion on one of the vertebral arteries or at the top of the basilar artery does not necessarily lead to relevant flow abnormalities. So with the color-coded sonography now, again, it's a diagnostic method allowing for non-invasive imaging of our transcranial vessels. And it combines the B mode with the color coding with the color Doppler. This allows us to actually visualize and identify the vessels properly. Reveals vascular and parenchymal anatomy as well. So we could see the vasculature, we could see the surrounding tissues. We can detect a wider variety of pathologies with this now because we have actual images of the vessels. We can monitor intracranial artery stenosis, and we can more accurately confirm occlusion. So with color-coded sonography, we're going to utilize our transtemporal and suboccipital approaches. For transtemporal, one of the things that we're going to look for is this hypoechoic butterfly-shaped midbrain. So this is the anatomic landmark that we can utilize to help get our bearings. This is kind of the midbrain, falx cerebrae, or the middle cerebral fissure, separating if this is the right approach, the right left brain. This is that hypoechoic butterfly that we look for in the midbrain to kind of get our bearings. So when we do this, our notch is going to be pointed towards the patient's nose. So this is going to be the notch. It's going to be anterior. This is going to be posterior now. So that's important to remember. Whichever side you're coming from, notch is always directed forward towards the patient's nose. So transtemporal, middle cerebral artery should be coming up towards us. Anterior cerebral artery kind of coming away from the transducer beam. Here we can see middle cerebral artery, anterior cerebral artery going away. We have posterior communicating, and then our posterior cerebral arteries towards the back of the head. There's a better picture. And we look for that hypoechoic butterfly as our landmark. When you put your color on, that middle cerebral artery coming up towards you, anterior cerebral artery going away, posterior cerebral. Transtemporal approach. Like flow directions, anterior cerebral going away, middle cerebral coming up towards you, posterior cerebral artery. Not really seeing the communicating artery there very well. In terms of vertebral artery, we're coming from that suboccipital window. So in this case, we see the foramen magnum we're scanning. We can also see a hyperechoic structure that's the clivus. That's another landmark that we utilize. But in this case, now we're looking for the two vertebral arteries coming away from the transducer, converging together to form that basilar artery. So it's kind of, you're typically gonna have to be a little bit off axis, either come a little bit to the right or a little bit to the left. So it's never gonna be like this nice perfect Y, it's gonna kind of be a little bit at an angle. Here's a nice picture. Here, upper tubular arteries coming together, so blue representing away from the transducer, coming together and forming the basilar artery. So down here, this arrowhead, this is another landmark, this hyperechoic clivus that we can see as well. So for stenosis, we're looking for greater than 50% diameter reduction to indicate stenosis. For hemodynamically significant stenosis. So this was showing peak systolic velocities that we would see to indicate, you know, greater than 50% stenosis with 100% specificity and sensitivity. But again, we're focused more on the mean velocities. So this is just showing some peak systolic velocity measurements. This was transtemporal window. Got MCA flow. So before the stenosis, velocities within normal range. At the stenosis, we got 300 centimeters per second. This was a middle cerebral artery that was occluded. They administered some blood thinners. And then several days later, that blood vessel recanalized and reopened. They were able to demonstrate flow within it now. So we're just some Dopplers now coming from the basilar artery in a patient that in a stroke patient with anterior circulatory symptoms. They had asymptomatic basilar artery stenosis and a subclavian steal phenomenon as well. So we said with sickle cell anemia was one of the indications for doing this exam. Again, sickle cell is an inherited disease caused by a defect gene mutation in the hemoglobin. So causing the erythrocytes, the red blood cells, to have a sickle shape. They're very fragile, they break easily. Because of that shape and their vulnerability, they can adhere to the blood vessels, causing a blockage. So we get narrowing and blockage as a result, you know, patient having sickle cell anemia. And that could lead to pain, swelling of the extremities, decrease in immune function, gallstones, kidney failure. But more importantly, it makes these patients susceptible to developing a stroke. So this was an 8-year-old patient with sickle cell disease. They had mean velocities of over 200 centimeters per second within the middle cerebral artery. And then with the CTA, they were able to see, MRI, they were able to see the area of narrowing within that middle cerebral artery. So correlated with their Doppler findings. Patients who have arteriovenous malformations, so these are congenitally fistulas that are congenital that they're born with. Since it's a fistula, we have increased flow velocities. We have reduced pulsatility or reduced resistance. So in that feeding artery, we'll see elevated velocities that are very low resistance. These patients will have reduced responsiveness to increasing CO2 levels. These allow for localization of arteriovenous malformations and hemodynamic state. Since it's a fistula, the drains, if we were to Doppler any of these draining veins, they'd be very pulsatile. There'd be no response to Valsalva because of their increased pulsatility. We'll have very high flow velocities, and severe flow disturbances at the site of that fistula. So monitoring. So we want to monitor these patients for the potential development of vasospasm. So vasospasms, I want to say it's a slow process, but it takes some time for it to develop, and we could see these vasospasms starting to develop. So that's why they often put these patients who have subarachnoid hemorrhage or brain bleeds on continuous transcranial Doppler monitoring. So they can monitor the velocities within these vessels. They can see them as they're slowly starting to creep up. And the doctors know, all right, there's impending vasospasm. All right, the velocities are starting to, creep up. We have to intervene and kind of get ahead of it. So it's used in intensive care unit monitoring. It's also used intraoperatively as well. So vasospasm is a common complication which may occur, within 4 to 14 days following the subarachnoid hemorrhage. So it doesn't occur, instantaneously. So we're in that post period after they've had some sort of brain bleed or brain trauma causing bleeding. So they'll start monitoring, in that early period, and they'll either continuously monitor, or they'll come back, every day, do a transcranial Doppler, in the morning, have them do it serial. So subarachnoid space is the area between the brain and skull. It's normally filled with cerebrospinal fluid and acts as a floating cushion to protect the brain. So when blood is released into this subarachnoid space, it increases the pressure on the brain, making the person confused, lethargic. It's often caused by either an aneurysm rupturing, or arteriovenous malformation, or trauma. So again, any sort of traumatic brain injury and injury. So motor vehicle accidents, those types of things, crashes. So transcranial Doppler allows for a non-invasive way to monitor and study blood flow velocities in these arteries, providing valuable information in patients who have subarachnoid hemorrhage before and after surgery. So there's something called Triple H therapy: hypertensive, hypervolumic, and hemodilation. So again, depending on the patient's injury or the patient's symptoms, we might want to have the patient in a hypertensive state to promote flow. We want to have adequate flow volume perfusing the brain, and we might have to thin the blood out. We want to dilute the blood. So transcranial Doppler can detect increases in velocities before the onset of symptoms, hours to days in advance. It allows for early diagnosis of cerebral vasospasm. So early detection in these patients that are at high risk for developing ischemia. It also allows for monitoring the benefits of available therapy for prophylactic treatments. Our color-coded sonography can also help to visualize and detect presence of cerebral aneurysm. So when we look for vasospasm, it's most accurate in the middle cerebral artery. We said normal velocities are going to be less than 120 centimeters per second, with a hemispheric ratio less than 3. Balloon angioplasty is the most common endovascular treatment. So if the patient is having a vasospasm, they can go in with the catheter. And the tip of that catheter is that balloon, which they can use to inflate to try and open up that vessel. They can place a stent in there if need be to keep that vessel open. So this was a patient with a vasospasm now. So here we have some waveforms coming from the right and from the left. So here are your right velocities, your left velocities. So we have middle cerebral and anterior cerebral. First, so mean is 124, mean 156 on the right compared to the left. Mean is 72 and the mean is 70. This was someone that's on that continuous monitoring now. So again, they're taking sample recordings at time intervals. And they could see as it's progressing, so day 2, day 3, day 4. So as they're getting into, that day 4 and beyond period, they're monitoring velocities within those vessels and they see them kind of cross over into that threshold. Of now entering into potential vasospasm. So they're seeing it on both sides here, first on the right, and then also now a period on the left. And depending on where you are, what lab, the values can vary slightly. So this is from one of our textbooks, or one of the textbooks I used to use. They had normal being less than 120 with the ratio less than 3. And then mild, moderate, severe in terms of vasospasm. This was the chart that Christianity uses. So they have mild starting all the way down to 85, going to 120, and then moderate and severe. So really they look more at the moderate and severe in terms of, notifying the doctors and calling their critical finding. But that index is still anything greater than 3 for that hemispheric index is considered abnormal. Severe will be greater than 6. So we have very, very elevated velocities in the middle cerebral compared to the ICA velocities. And then they use, again, over 80 for the posterior vessels for PCA. Well, PCA. So PCA they use 100, 80 starting for mild, 60 to 80 for mild, and then over 80 for moderate. Transcranial Doppler, you might also encounter intraoperative. So it's again a non-invasive way to allow for continuous monitoring of cerebral flow within the OR, and we could detect rapid changes in blood supply. Delivers direct and immediate information regarding cerebral perfusion, allowing for rapid modification during surgery. So it's been used when we have to perform carotid endarterectomies, open heart surgery, as well as intensive care therapy. So again, with that intensive care unit monitoring, we're going to use that helmet-like device for the continual monitoring. So again, primarily used for patients who have had subarachnoid hemorrhage, brain bleeds. When patients have increased intracranial pressures after a head injury. If there's severe cerebrovascular occlusive disease within the cervical vessels, or maybe a potential dissection. Patients who have hydrocephalus, so this is accumulation of a cerebrospinal fluid within the ventricles that can lead to increased pressures within the brain. If there's low flow states associated with extracranial occlusive disease, we want to see perfusion of blood flow within the brain. If they have really bad carotid artery disease, we can do continual monitoring. Patients who've had heart attack, myocardial failure, or other vascular disease, and we can use it for determining impending brain death as well. So this is a patient who had a brain aneurysm that ruptured. They had a brain bleed. They did a treatment, a coil treatment to embolize that vessel to stop the bleed. And then they demonstrated velocities now. So in the middle cerebral arteries, we had 130. And then in the basal artery, we had 219. So it was that posterior circulatory symptom or pathway that demonstrated the vasospasm in this case, or the significant vasospasm. They performed angioplasty to dilate the arteries that had critical spasm to help prevent potential CVA. Showing grayscale color and power angio of the left middle cerebral artery after placement of a stent. To get some flow utilizing their power Doppler. So one of the other things that we can actually detect with transcranial Doppler is the presence of these little microemboli, so little pieces of either atherosclerotic plaque or clot circulating at a microscopic level within our cerebrovascular circulation. So this might be a good indicator, of how severe a patient's stroke is, or if they're still at a risk for having further progression of that stroke by detecting these little microemboli that are circulating. So detection of microembolic signals is referred to as MES. We also like to call them HITS, or high intensity transient signals. So these are actually little chirps or little bright spikes on our Doppler tracing that we can pick up. They occur at random locations within the cardiac cycle. They're for a very short duration, but they're very high intensity. So they actually sound like little chirps. So they're very high, loud Doppler signal. They permit for assessment of actual thromboembolic risk and permit for monitoring of treatment efficiency. So on our Doppler tracing, we'll see these very little bright spikes. So they can be anywhere along that Doppler tracing. And the more of these that you see, that represents more microemboli circulating through the patient's systemic system. So power M mode can actually track the emboli in time and space and provide simultaneously real-time assessment of emboli passing through different vessels, thereby increasing the yield of detection. So that machine has this function doing power M mode, where we have color with the M. We can kind of pick up. It allows for better detection of these microemboli using the angio, the power M mode. With the Doppler tracing, then you can see some of those hits, some of those spikes. So some of these, are associated with the more intense ones. Like I said, we could use this to determine if a patient has a PFO. In this case, we detect a PFO is a right to left heart shunt. So in this case, blood flow can go right from the right atrium directly into the left atrium through that foramen ovale, that patent foramen ovale. So with this patient wearing special headgear, we can assess both MCAs simultaneously. So to detect the presence of a PFO, what we'll do is actually administer agitated saline. So that's our contrast agent. So we'll take a bottle of saline, agitate it, create these little bubbles within the saline, and then inject that directly into an arm vein. And then if the patient does have a PFO and that blood flow can go from the right atrium to the left atrium, we'll pick up those microbubbles now in the systemic circulation, and you'll see lots of these little hits present in the systemic circulation now. If the patient does not have a PFO, it'll just, enter into the right atrium, right ventricle, or go to the lungs and just breathe out those air bubbles, those little microbubbles. So they just get expelled. It sounds dangerous injecting bubbles into your veins, right? So in order to, one of the things with that injecting the contrast agent, we try and provoke the patient. So we'll have them either cough or sniff or Valsalva to try and elicit Those bubbles crossing over as well. And then we can determine the severity of that, PFO or the significance of it, try and grade it based off of the number of hits or microbubbles that we see on the other side of it. So this was an example of a positive bubble test now. So we see a whole lot of hits coming across. So this would indicate, a very large PFO or a very large right to left shunt. So again, this is clinically significant, if a patient has had a stroke, we know that because of this, they have a positive, they have a large patent foraminal valley. That DVT in the legs could easily have traveled across that and been the cause or culprit for their stroke. So then we have to investigate thoroughly, their lower extremities or their body, for the presence of blood clot that could have caused that stroke. So you could potentially grade, the size of that left to right shunt based off of the number of embolic hits that you see, those hits. We've been talking a lot about arterial occlusion and stenosis, but the issue could be on the venous side. So patients can develop cerebral venous thrombosis. So with the color-coded sonography, you can also visualize veins as well. So any abnormal elevation of blood flow velocities within the cranial sinuses, direct visualization of the sinuses with decreased or absent flow. So we can actually potentially see clots within the veins. We also use it to determine impending brain death. So there are clinical criteria that have to be met in order to, determine or make the diagnosis of brain death. So in addition to our Doppler findings, we also have to perform an ECG, so an electroencephalogic exam. So that might be, you see, they put like the little electrodes all over the patient's brain to monitor, electrical activity within the brain. So angiographic demonstration of absent intracranial circulation. So they would do an angiography as well. So we can demonstrate cerebral circulatory arrest. We might see when that's present, we might see reflux phenomenon and late systole. We see increasing resistive indices. So it must be used in conjunction with clinical and other laboratory markers for to make that determination of brain death. So the brain death, it's a progression. So we go from what we expect to see normal, low resistance, flow within the brain. The flow starts to become higher and higher and higher resistance. So we get less and less and less diastolic flow. Until we get no diastolic flow, very high resistant. And as it continues to progress, we can start to see reversal of flow. So now we're entering into triphasic. During diastole, now we see reversal of flow. And then eventually, as the brain death progresses, it peters out and then, zero flow. So again, if we're doing a transcranial Doppler now, and we see very high resistant flow, that can indicate one or two things. It can indicate, either a more distal obstruction. But if we see reversal of flow like this now, that more likely indicates the patient is going through, impending brain death. So effective assessment of effects of extracranial occlusive disease. So if a patient has extracranial disease, so if we have diseased carotids, we are going to see changes in some of our flow directions and flow patterns, and we have to be able to recognize that and try and potentially determine where that disease is based off of what we're seeing now. So if there's carotid stenosis or occlusion, it's going to alter the flow directions. So TCD and the color-coded sonography are used to identify collateral flow in patients that have extracranial disease, that have disease in the bulbs and bifurcations. The four main collateral pathways that can be distinguished are via the anterior communicating arteries, via the posterior communicating arteries, via the ophthalmic artery, and then ipsilateral leptomeningeal arteries. Yep, circle the Willis picture. All the way up. Circular Willis. Oh, no, that's a decent one. I like this picture because it has the normal flow directions, you know, that you'd expect to see in these vessels. So typically, you know, the anterior communicating artery, there isn't much flow, if any at all, in terms of flow direction. But it becomes critical when we do have blockages, you know, in our ICA, when we have disease extracranial within our ICAs. You know, that ACA becomes critical, the flow direction across it and the flow direction in the anterior cerebral arteries. So now you have to just kind of think about it, you know, logically now, what we expect to see. So if I have a blockage, you know, in this ICA, there's little to no blood flow getting into these vessels now. So we really want to feed, you know, all these territories of the brain. So all the lateral and anterior portions of our brain, they're starving for blood flow. This is blocked now. We have to get blood flow, you know, into the anterior cerebral artery. So really focus on, you know, getting blood flow into these areas and these areas. So again, the body has a couple of different options now. So our normal flow direction in our posterior cerebral artery is from the anterior into the posterior circulatory pathways. So if it's now the vertebral on this side is acting as a collateral, we'll see change in flow direction in that posterior cerebral artery. So we can pick that up. We'll look for change in direction. So instead of being away from us, it'd be towards the ultrasound beam. Blood flow on the other side now. This side's blocked. We got to get blood flow into those pathways now. We'll have increased flow in our ICA. You know, potentially elevated velocities in our anterior cerebral artery. And now flow direction in that ACA is going to be going, you know, from left across into that anterior cerebral artery. Now it's going to be retrograde in this segment. So normally we're Dopplering, you know, this portion of the anterior cerebral artery. Normally it should be away. If we know the patient has disease on the right side, the ipsilateral ACA will be retrograde, bring blood flow into the middle cerebral arteries to feed that portion of the brain. Blood flow is going to be coming up this way across the anterior communicating. Blood flow then will split. We'll have blood flow going in the remainder of that anterior cerebral to feed all that portion up there, but we'll get retrograde in that segment of the ACA that we typically image. So you can tell, you know, if the patient has, you know, disease based off of, you know, what you know, extracranial, and what you expect to see. So if I have an occluded ICA, I expect to see retrograde flow in the ipsilateral ACA in order to bring blood flow into that middle cerebral artery to bring it out that way. If I have the blockage on this side now, I'd expect the ACA to have retrograde flow, the ipsilateral, same side ACA, to have retrograde flow. And it's being fed by, the right ICA in this case. And coming across, right, from right to left, retrograde down this ACA to feed and fill the MCA on that side. So again, both look at kind of get siphoned off, you got some going that way, some going that way. And then potentially again, it's on this side, we'll see flow towards the transducer in that posterior communicating artery. Question, how was it going?
Will both of them happen at the same time or just one of them? Or both of them?
Yeah, they could, sure. Yeah, you can have both at the same time. Whatever it can, to get blood flow where it needs to. No windows. Transorbital, transtemporal, suboccipital. Show you the text. So MCA elevated, so both of them are high. So vasospasm or stenosis in the middle cerebral, anterior cerebral. So comparing right to left, always compare right to left when you look at these. See if I have a good question, which is not a main collateral pathway in the event of IC obstruction. We talked about a couple of different ones. We talked about branches of the ECA connecting with the ophthalmic artery for sure, that's that, or extracranial. Anterior to posterior pathway, so going from that through the posterior communicating arteries, going from the anterior circulatory pathway to the posterior.
Yeah. And the
Or, sorry.
contralateral.
And then contralateral, so that's using the anterior communicating artery from one hemisphere to the other. Good TCD question. There you go. So. Left anterior cerebral artery. Let me see if I make this smaller. Put it next to that. Even though you guys might hate it when you get to your vascular boards, maybe draw this as best you can off your memory. And at least then you'll have a picture. So, all right. Left anterior cerebral artery flow is towards the sound beams. So,
It's supposed to be away from.
yeah, so I have coming towards the sound beams. So what does that mean now?
Is it contralateral ICA obstruction? Yeah.
It's ipsilateral. Yep, so that means that there's no blood flow getting, in these pathways.
Mm.
Because this is obstructed, the blood flow is coming up that one across and down. So it's ipsilateral carotid obstruction with right to left collateralization, so it's going from the right side to the left side. Up, down. That's the level of vascular board questions that we're gonna get you to.
You definitely need to memorize that.
Granted, it's not a large section, so if you could get a couple of them, we'll get you there. So we can use transcranial Doppler to, assess subclavian steel, the mechanisms of it, how significant it is. If it's really having a drastic impact on perfusion. So this was just going some limitations of transcranial Doppler. Again, you need a lot of operator experience in proper, settings, poor windows. Patients have recent eye surgery, limit that, add some covariance. Patient willing to cooperate and stay still. We said any sort of intracranial mass could displace where the arteries run or are located. Misidentification of vessels, since we don't have that picture to really, go by. And then misinterpretation of collateral channels or vasospasms as an actual stenosis. So functional reserve testing. So transcranial Doppler is ideal for a functional test for detecting rapid changes in cerebral perfusion. So with changing CO2 concentration levels, there's a relationship between the velocity and the volume of flow within the large cerebral arteries. Intactness of this vasomotor reserve implies that a drop in perfusion pressure can be counterbalanced by vasodilation of these cortical arterioles and maintain sufficient blood supply to the cerebral vasculature territories. This vasomotor reserve may be exhausted if the vessel resistance of the vessel, if the resistance in vessels of the brain areas with low perfusion are already maximally dilated. So basically this is saying that we could kind of chart and map, play around with the patient's CO2 levels and monitor the amount of flow to see if this patient still has some reserve left in terms of the ability or amount of these that their vessels can dilate. So with this first functional reserve testing, they actually placed like a mask over the patient, increase their CO2 concentrations within their blood, and then monitor the velocities. Um, Yeah, so with this test, it could be useful, if a patient is having a vasospasm, they would try and vasodilate, increase the CO2 levels. And then they could tell whether or not, that is enough, perfusion. They could tell if the vessels are maxed out. So if they're administering the CO2 and they've reached a point where they're not getting any more, vasodilation, any more increased flow, they might have to go in with another procedure, try to stent open the vessel, or, perform that angioplasty. Or otherwise this patient becomes a risk for, not hypoxia, but, ischemia, within those brain tissues. Ultrasound for pre-mission imaging. So now that we have contrast agents, ultrasound contrast agents, this allows for better imaging of our cerebral vasculature. So we can introduce these contrast agents via intravenous bolus. So this was a patient who has a cerebral infarct. So with 3D ultrasound, we can also get 3D renderings now for intracranial vessels. So this was in conjunction with the use of ultrasound contrast. So I mentioned about sonal thrombolysis. So ultrasound assisted thrombolysis is the installation of a thrombus alone or in combination with these fibrolytic agents to accelerate the thrombolytic process. So they would use frequencies between 20 hertz and 3 megahertz, so a very low frequency transducer, to try and rupture or burst those contrast bubbles in order to release their thrombolytic medications that are infused within those bubbles. So this may increase the efficiency of a pure pharmacologic approach for thrombolysis in acute stroke patients. So we're trying to deliver those thrombolytic medications directly in the area of the stroke. So use of contrast, echocontrast enhanced agents can enhance the effect of further microbubble induced cavitation. So establishing thrombolysis as a therapeutic tool could revolutionize the treatment of an acute stroke. The risk for intracerebral hemorrhage is currently under investigation. So again, you don't want to, administer medications that could cause bleeding or break up clots if the patient already has a brain bleed going on. So, that's something that we want to consider. So this is acute thromboembolism on the MCA. This is an acute clot within the middle cerebral artery. And then we see slowly resolution of that clot, so slowly getting better. So initially there was absent blood flow, then minimal. Then as that clot slowly breaks down and dissolves, we're starting to get more and more blood flow present. So just showing the progression in patients, who are undergoing thrombolysis treatment as the vessel slowly starts to recanalize. So just think about it, kind of, you know, physiologically. It's occluded, there's a clot sitting in there, they've administered clot busting medications to try and lyse it, bring it apart. So we have no flow, and then just very minimal flow. Then a very low amplitude blunted waveform. Um, and then as that clot starts to break up now, and we're starting to get some blood flow getting through now. The channel is very small, so it's gonna appear as a very stenotic waveform as it's starting to recanalize. And then the clot is breaking up, dissolving, and then once it's gone, you have a normal, arterial waveform. That's basically what that chart is trying to describe. Again, just keep in mind, when we do administer these contrast agents, they really enhance our echo signal. So because of that, we'll look like, we're getting that artifact where we have color extending past the borders of the vessel, so this is referred to as ballooning artifact. When we see that color extend past the borders of the vessel. With that, we also can have elevated velocities as a result of the use of the contrast. So because it's such a strong reflector, the velocities might appear elevated. But use of contrast will help us to, better visualize. So this was showing an occlusion that's starting to, so a clot in a vessel that's occluded. They're trying to break up or dissolve that clot. The blood flow is starting to increase. So we start with the slow flow, higher resistant, then we get into stenotic lesion, then a return to a normal waveform, and then now it's starting to restenose again. In this case, it's now clotting back up, re-occluding. I don't know, I think this is Lily's trip. And she is a world traveler. So she put some pictures on here from some of her travels. I think it was kind of like a breather. This woman, she retired. I call her like, "Where are you going, Lily?" "Oh, I'm gonna spend some time, see my family in Taiwan." She went to a cruise to Antarctica, like a transatlantic stuff. She thinks she's touring Europe right now, like traveling Europe. That is the life. It's Lily. I got her in the back. That's very cool, yeah. She's looking long. Oh yeah, she got show me pictures of the penguins and stuff. It's super great.
See that stuff in the sky. How are it called? Color.
So Dan, are we doing this at some point? Are we doing the,
Transcranial?
yeah,
Yeah, I'm gonna arrange for you guys. They do them very early in the vascular lab. So we have to coordinate with the vascular lab who's doing it. They'll have you come in at like 6 a.m. and you'll just leave clinical early. And you can shadow and go. Sometimes they do them during the day. Not usually. They usually try and bang them out in the mornings.
okay.
You guys who go to Nemours, the DMS people, like they do them on the little babies. So pretty sure they use the color, the ultrasound. As opposed to just the transcranial Doppler. Christian Vascular just does the Doppler, so there's no
Okay.
ultrasound. Usually they have their own Doppler machine. They were gonna give me one, but like apparently they couldn't clear out all the patient data off it. Whatever. Oh, that's not one of it. Um. It's tough, it's challenging, because it's basically like that, how you fishing around for the vessels. And you're just going blind, kind of just like, all right, like I gotta angle a little more this way, increase my depth, and just it's tough. Like, I mean, once you get the hang of it, I guess it's not so bad. People that do it are usually the senior techs that get there early. They've
It's like his favorite thing ever.
really,
He loves doing the cranial. The,
Greg,
you know, the travel tech,
oh, travel tech,
he was like, most of the time when he was traveling, like, he went to New Mexico, like, to strictly, like, yeah, because they offer. He loves the cranial.
hello? Yes. Yeah, well, I'm still here, I just finished up. Well, just lecture, I have lab now. What's going on?